thrilled to introduce Dr. Ron Wyatt as Vice President and Patient Safety Officer at MCIC Vermont. Dr. Wyatt is the former co-chair of the Institute for Healthcare Improvement Equity Advisory Group and is faculty for the IHI Pursuing Equity Initiative. Dr. Wyatt is here to share his knowledge and expertise with us on methods for measuring health disparities across different populations, including understanding the advantages and disadvantages of various methods. So with that, I will stop sharing my screen and pass it off to you, Dr. Wyatt, to get us started.
Thank you. Am I going to share my screen or?
Yes, yes. And I think
Okay.
you should be able to have the.
Okay, see that okay?
Yep.
Okay.
You can now. Thank you.
Yeah. So thank you, everyone. And again, my apologies. It is really, truly a delight to be with you. And I am, although my company says MCIC Vermont, my office is in New York City, headquarters in Atlanta, but I am in LA, which for me means Lower Alabama. So I'm almost at the Gulf of Mexico to talk to you. I'm an Alabama native, born in Selma, Alabama, which some of you likely heard of, and grew up in a nearby town that happens to be the hometown of Coretta Scott King, who's my cousin, during the Civil Rights Movement there in what's called the Black Belt in the state of Alabama. So it's a delight to be with you to talk about this topic. And let me see. My screen's not moving. There we go. So the objectives, we're going to talk about health equity and disparity and the measurement part of this. My understanding is that you've already spent some time on historical perspectives and root causes. So we won't go into those except to say we need to fully understand and not be ahistorical when we talk about disparity and inequity. And these days I spend probably more time using the term health and healthcare inequity that you see on the screen. It's important that we have in the improvement world a set of operational definitions. And off of that, we begin to build our measurement system. So then when we think about health inequity, there we're looking in the data. We're looking in the data for what are those differences? And we're looking at the outcomes. And I think in the measurement world, we all know the value of structure and process. So let's assume that there are structures and processes that we need to look at to get to where are there differences in outcomes, and then beginning to use measurement, using data, using analysis to see where are there systematic inequities, where are there avoidable inequities, and quite frankly, where are there unjust inequities in the data, in our measurement, and then how do we begin to build a system of measurement that helps us better understand what we're trying to measure so that we can improve care. So then when we think about health equity measurement, then here's just a definition that comes out of HHS. And what we're trying to do is to illustrate, and in some cases, and I'll show you this later, how to summarize the care being given and how we can use those illustrations and use those summaries down to a community and population level so that we can begin to build a measurement system that displays, that summarizes, that illustrates where are the social risk factors built into the systems that we can begin to design better systems. So without reading through this is, again, what if you thought about what would an ideal health equity measurement approach look like? So we have to have measures that we just talked about. We need to look at where the evidence is. And again, making that connection to social risk factors in health and healthcare as it relates to outcomes. Then what are the incentives to improve care? How do we improve care for at-risk people in the population and communities? How do we know that we have valid data, that we have then off of valid data, the appropriate benchmark, and quite frankly, for me, not so much an and or, but a benchmark for the reference group, if we say that, and we can say populations that are marginalized, under-resourced, and the language that we use in order that we can no longer put the populations that are marginalized and under-resourced in the same group with another population. So we have to use data to demonstrate that. And then out of that, always in improving care, improvement science, is what are the unintended consequences of our work, and making sure that at all times we're looking at what we call balancing measures so that we don't make matters worse when we think we're trying to improve those. Again, the value of measurements, making sure that your interventions, the ideas that we have, the hunch that we may be testing, the hypothesis that is being looked at is not in fact making things worse. So then thinking through, what are the requirements around measurability and how reliable are the measures? And in fact, can we then introduce some type of change idea or change package based on the measurability requirements so that we can move into how we begin to, I would say, eliminate health inequity and to achieve equity. And then looking at what are the groups and subgroups that we can begin to understand the data and understand whether it's precise enough, and then how can we link that back to provider performance. And I will share an example of that, hopefully, when we get back to some of these examples. So again, why do we measure? Well, in the environment that we're in, there's three big reasons. And I already mentioned one, that is to improve care. The next is that we can inform populations and communities, here what's called consumers, and increasingly it is to inform payers. And one of the two, now three equity collaboratives that I work with are either fully supported or heavily supported by payers who have explicit deliverables that are all data driven around healthcare disparity and health equity as expectations for either payment or, quite frankly, penalty. So then, as I said before, when we think about reasons to measure to improve care, here we're talking about the things that I have enclosed in the box there is that we're trying to improve care. We're trying to improve the service that we deliver. And the approach that I'm trained in is what you might know of as PDSA or PDCA cycles, or sequential observable tests that rest on just enough data. And those are those small sequential samples where we can begin to test an idea, test a hypothesis. Inside this data, there's going to be some consistent variation that we need to accept. That's very different from measurement for judgment or measurement for research. And then how we begin to move that data into graphical displays and for improvement of service or improvement of care. Here, my preference and what I'm anchored in is how we begin to use statistical process control, run and control charts to demonstrate that data. Let's see, slide stuck. Okay, so then when we think about the steps involved in measurement for improvement, these are the steps that you have displayed here. First and foremost, and the biggest challenge, even in the work I do now at MCIC Vermont, is do you have access to the data? So getting access to data, understanding, is the data robust? Is it valid? And then after we analyze it, can we then go to step one, which is what are we aiming to do? And based on what we set as an aim, we choose our measures and metrics. There has to be then a collection plan. So all too often I ask groups and teams, what is your data collection plan? And what is your period of time that you will use to collect baseline data and then analyze that data? And then you continue through that cycle as you work towards your aim. That means for improvement science, that you can go back and redesign or innovate, or you may decide that your intervention made things worse and you just need to stop and rethink it and start over. And innovation is really nothing more than redesign. So then if we think about just this hierarchy that's demonstrated from IHI and from there you see Bob Lloyd that's referenced, and really Bob Lloyd continues to be a teacher of mine. is when we look at this hierarchy of measurement, what we begin to look at is this pyramid of process, from focusing on the process to working towards a desired outcome. And then this work, it is to eliminate inequity and eliminate disparity. So going up that hierarchy from the very front line, from the macro system to the meso system, where you have managers and project staff, service managers, all the way up to the macro system. That's the governing board, the CEO. And you see that you're moving gradually towards understanding that your processes are working, that there are structures in place, that the process that you declared is being complied with. And you continue to measure your outcomes as you go. And then you continue to say, what are the balancing measures that we need to be taking a look at, and put together some construct of what I would call a data collection plan. And this is just an animated example of a measures template. And where I started was, what's your definition? So you need a definition of a measure. And truly, I would say, look at numerator and denominator data and how you calculate, and what group are you aimed at in terms of measurement. How are you setting your goals? This should be a numeric goal. And then the accountability part of it, who's responsible? When will it be achieved? So putting that information in, the same for a measurement process. As I said before, is the data available? Who is accountable? Who's responsible for collecting the data? And what is that process? And you have to continue to revisit that process to make sure there are no breakdowns in the process. So for example, back a decade or more ago, when we looked at the central line associated bloodstream infections and looked at the care bundles, and even in the hospital where I practiced, there was a collection process, but it drifted, so that a bundle was judged to be in compliance process-wise, not if all 5 of the components were met, but 3 out of 5. So you can see how that drift can occur and impact your data and lead you off in a path. And then sometime later, you realize we really didn't improve central line associated bloodstream infection. And that happened in all too many places, all too often, when you begin to shift and drift how you collect the data, how you analyze the data, how you, in some cases, go back and redefine your aims and your goals. And what we say, and some of you have likely heard from the IHI, is that hope is not a plan, soon is not a time, and some is not a number. So as you think through your measures template, take away the hope, which we always want to have that, but it's just not a plan. And if we're going to improve one day, well, that's not a time. So be as specific as you can. Well, here's a summary of just examples from literature on some ways and sources to think about health equity measurement. And I won't go through all of these, but what's most important, I think, as we work on health inequity, is look at the social risk factors. We talk about what's called social determinants of health or non-medical determinants of health, but we have to move away in terms of measurement from what all too often has been what's called central tendency. And then we apply the central tendency rules to people that are at really high social risk. And that could be related to race, ethnicity. It could be age and sexual orientation or gender identity. It could be insurance status. So understanding if you have social vulnerabilities and how you begin to look at that in a different way. And that's been part of the discussion around ranking and rating systems, particularly as it relates to hospital penalties. For instance, a readmission penalty. And if you put in every population into your readmissions data, it can really be misleading if you don't apply social risk. So again, a real life example of that was when I was at the Cook County Health System. We looked at our readmissions data, and we looked at what's called EDAC. I'm going to assume some of you are familiar with EDAC, which is just the people coming back to the emergency department after they have been discharged. So they come back, either they're put in observation or they're readmitted or they're seen, assessed in the ED, and then they leave. So when we looked at our data at Cook County, for example, we looked at readmissions. And what we discovered was that the population that was most likely to be readmitted or to come back to the emergency department, and we could get this specific, and there we used the Vision Clinical Database as well as the Cerner electronic health record. That patient was a 52 to 54-year-old Black male with a primary diagnosis of congestive heart failure. So we said, okay, that's going to drive the next question, why? And the patient safety part of me will never leave, which is why this population? So when we began to look at the entire process that's leading to an outcome that none of us want to see for the system, but also especially for the patient, what was it that's driving that? And we don't have time in this talk to get into how you begin to set up a driver diagram. I'm going to assume many of you know how to do that. So what are the drivers? What are the primary drivers for that population? And we looked at we mapped it out from when the person came into the hospital with the diagnosis of heart failure, went to the heart failure unit, and then the care transitions process before they left the hospital. And it did not take us long to realize what was happening. When we looked at the demographics of the patient, we were asking, where will you go? What is your home? What's your home address? Where do you live? And what we discovered that the majority of these patients were either homeless, they were homeless. They lived in a shelter, they lived with family or friends, or some lived in their vehicles. The other thing that emerged was that many of them had either alcohol problems or substance abuse problems. And that's data that we didn't have. So I'll probably say no data is also data. So when we said, well, are we including this in the care transitions process? Do we now bring in social services to try to address the fact that not only is this person homeless, but they have these other social issues that they're trying to manage or not manage, and they end up back into the emergency department. The other part of that was men who could not afford their medications, and they did not say that. And a part of that, for all of you to understand, is, and I'm sure you do, populations that culturally won't tell you that they cannot afford something. It's a matter of cultural pride in some cases, that those men were not saying, I don't have the money for my prescriptions. So we had to bring in pharmacy and social service and all those things to better understand that population. So then when we think about setting up a health equity measurement approach, these are just some examples to think about. I just shared one with you, but look at the evidence. And what are the evidence that you need to understand? In this case, it was these social factors around homelessness. And then is the data usable? Can we design some improvement around a population that's socially vulnerable or socially at risk? Again, that word, what are the unintended consequences? And how do we begin to look at people who have higher social risk factors and measure them in the same way we measure some other population? I will say we can no longer do that. And then how do we begin to apply this knowledge? How do we begin to know that the measurements are reliable, they're repeatable, they demonstrate the performance of a program or a provider or providers or a site or a location? And are we collecting the information on these groups that give us some idea, some hint, some clue about some inequity that exists in the system that we need to understand? And now, as you all are aware, we're in value-based purchasing world, and inside of value-based purchasing, there are these domains of measurement. The bluntest one in clinical outcomes is risk-adjusted mortality rates. So if you look at risk-adjusted mortality rate and stratify that by race, ethnicity, by language, by sexual orientation, gender identity, what is that risk-adjusted mortality rate for that population? That's inside of value-based purchasing. Under value-based purchasing, under patient safety, the primary metrics are hospital-acquired infections. Well, it's easy to set the goal. We use the NHSN definitions as the gold standard. And the goal around hospital-acquired infections is zero, except for one, and that's C. difficile infection, which is almost zero. So there you, again, have a data set. If you begin to collect data by race, ethnicity, language, sexual orientation, gender identity, or geocode, and stratify that data, a story begins to emerge. The other one that I implore all of us to begin to look at and think about creative ways to measure, and that is the HCAHPS data. There are 5 questions in the HCAHPS questionnaire survey that will be a focus of value-based purchasing, or is a focus of value-based purchasing. Those calculations have already been done. And if you look at those questions, and again, how can you begin to stratify that information along race, ethnicity, language, sexual orientation, gender identity, another story begins to emerge. And there are systems that are looking at the HCAHPS data, what now by CMS is called people and community engagement. And those are those questions that, I would say we really need to begin to understand, look at, and drive care. And then the fourth domain is effectiveness and efficiency. And that's what are the true cost of care for these populations. And the one that I use as an example there is when I was at a big hospital in the upper Midwest, and they looked at what was readmissions costing them as a system. And they did something similar that we did at Cook County, and they identified a population that was driving the data. It was a subgroup. It was Hmong females. So when the team there tried to understand what was happening, why was this population driving readmissions and driving readmissions cost, that always gets the eye of the CFOs, chief finance officers, if there's some in the room today. So they knew how much it was costing the system. And when they looked at the data and stratified and validate the data among Hmong females, one thing became apparent. It was women who had stage 3 renal insufficiency. And that was across the board for other populations. Not hard to get at that one. That the other population, they couldn't quite understand. So they brought in, which is critical now, they brought in a person from the Hmong community and asked that person to just observe the care transitions process. And it took the person less than a couple of hours to tell them what they were doing or what they were not doing. The population, the Hmong population, is a male dominant society. So the care transitions process, in essence, excluded the male member of the family from the care transitions process. They were not included. So then when the Hmong female got the care transitions information, including follow-up appointment, prescriptions, follow-up for diagnostic tests, since the male felt disrespected, he would say to the female, in essence, you won't do any of that because they disrespected me. So then the patient ends up back in the emergency department just for just a cultural oversight that we have to truly be mindful of. So then when we began to think about a measurement system, and this is from NQF, and setting up disparities sensitive measurement, this is the approach that NQF recommended. Looking at the prevalence in your community, measuring the gap and the impact, and we'll show you some examples of that. And once you do that, then you say, well, what is the gap greater than some number? And then how do we map the data that we've collected and the gap to our interventions, to our change packages, to where we need to improve? And I've given some examples of that through communication, care coordination, cultural competency that I won't spend a lot of time talking about, but to say that we need to think beyond cultural competency more to structural competency and structural humility, and how we begin to deeply understand the political, the economic, and the social factors that people and communities bring into care when they come to us for service. So here's just a few examples of some equity reports and examples. And I talked about quantitative, but they can also be qualitative. And I'll go back to the HCAHPS domain that I mentioned. And what I did at Cook County was not just rely on the drop-down responses on the HCAHPS survey, but we would actually read the narrative. And when we read the narrative, just the qualitative part of that helped us guide our interventions. So these are just a few examples that came from RAND this year on ways you can begin to look at building an equity report around COVID-19, around other comorbid conditions, which give you some examples. We talked about unplanned readmissions, and again, some examples of what to look at. At Cook County, we did look at hemoglobin A1C. We looked at vaccination rates in the pediatric population. We looked at colon cancer screening, and we also, again, as you heard, looked at care coordination. So using qualitative and quantitative information as you build your equity reports becomes important to do. As you all know, telehealth accelerated during COVID. It is dropped off some now, but it's not going to go away. So as you think about your population and your geography, then what is the penetration of telehealth, and beginning to build systems around telehealth so that inequities are not perpetuated and disparities not made worse. And again, I'm anchored in for this entire presentation at a minimum, beginning to collect race, ethnicity, and language data and sexual orientation, gender identity data. For example, that's again what some of the big payers are asking for. CMS is asking for. The Joint Commission is beginning to build a system to ask for part of this as a part of their standards. So across the board, the NCQA is looking at also how to bring them to some kind of standard for accreditation. I talked about value-based purchasing, and these are the things that I talked about that will be worth your data analytics teams taking a look at these and the performance standards. What's going to be looked at is what's the benchmark, the achievement threshold, which is defined as the 50th percentile, and then what's the worst rates. And again, those calculations have already been made. These are those domains that I talked about, and paying careful attention to these domains. And you can even start here with your data to say, do we have disparities? And then if so, what is systematic about it that's leading to inequities and outcomes in our system? And this can be done inpatient and ambulatory. We talked about this, and I'll mention it again, but just looking at alternative payment models and equity. And we know that there's been not a lot of success in improving disparities across the board. But in particular, when we began to look at alternative payment models, we have, in my opinion, punished people who are socially high risk. We also know, for various reasons, that Black people are underrepresented in accountable care organizations. Some of it is old term, it's just plain old cherry picking, where ACOs have not taken on patients that were considered to be at higher risk. So that needs to change as we look at alternative payment models and health equity. I'll refer you back to the Health Affairs paper that was published by some friends and really prominent people about a year ago. So when we think then about what are the pathways around value-based care and health equity, beginning to align that and integrate that in with pay for performance. We cannot do this without thinking about where are we spending our money and what are the costs. So begin to look at where is the community impact money going? Is it going back into communities so that we can eliminate disparities and achieve health equity? What are the community-based health interventions that we need to begin to think about and make more robust as a part of our equity? And all of these things, all three of these are measurable and should be part of our plan. So now I'm gonna move into a few examples of just health equity measurement. And again, measurement for improvement. This came from California, that was also published recently in Health Affairs. And HealthNet looked at cervical cancer screening. They defined the situation, low cervical cancer screening among members who self-identified as Chinese. And you can see there the solutions that they put in place, including hiring 2 female nurse practitioners in the FQHC. They created a wonderful infographic that you can find at the link, and they built a system. They put incentives into the system in order to achieve higher rates of cervical cancer screening. So again, they built a system and then looked at the results. An average of 51% of the patients with scheduled appointments with the female provider, and then a 4% increase in Mandarin speaking members for cervical cancer screening. That's real data. That's real improvement. And then the question always becomes, can we sustain this? So as a part of a measurement system and an improvement intervention, always think about early on, not later, how can we sustain this over time? So as we begin to think about then building a measurement system, these are the steps. This comes from Minnesota Children's, and I'm including it because several entities now are looking at how Children's of Minnesota built a measurement system that showed significant improvement in the areas that they chose. First and foremost, and again, this is not to be overly prescriptive. As you think about this, just think about where you are, and are you doing something similar? Is there something you can add to this, or will it work where you are? So again, not draconian, not prescriptive, but just some ideas and how Minnesota Children's built their system. First, going to look at what's the evidence, doing the literature reviews around health equity and how to build a measurement system and dashboards. Develop the metrics we already talked about, and be willing to refine your metrics and realize that you cannot boil the ocean. So pick a limited set of metrics where robust data tells you are valid, and you know that you can act on these. And the old term is, the low-lying fruit. I would say, think about it this way. What are the metrics that will either be high impact, easier to implement, but also high impact and more difficult to implement? If something is low impact and easy to implement, you probably shouldn't spend much time on that one. So think about where you're going to get the most impact and how challenging that's going to be to start. And then begin to think about how you will graphically display your metrics. Again, I'm anchored in using run charts and control charts, statistical process control. Make sure that the people are in the room that need to be in the room when these decisions are made. So engaging with stakeholders, as we call them. So clinical leadership, community leaders. If you have an equity inclusion team, and then hospital leadership, doesn't hurt to have someone from the governance board as a part of that. And a part of those conversations at Cook County, we did have a board member who was involved with our processes at all of the quality safety committee meetings for the system, as well as for each hospital. And then how you begin to communicate your measurement plan, including at your quality committees, safety committees, equity committees. I would present our data at the Cook County System Board monthly. And that was a public meeting. And anyone could come. And in fact, all of the media in Chicago, WGN, WBZ, Chicago Tribune, the Sun-Times, were all in the room at the board meeting when we presented this data. So then as you think about, this is again, Children's of Minnesota, when you think about, well, okay, let's take those steps now and develop equity measures. So you see there are the leaders. You start with an improvement process. Brainstorming is a tool that's in the toolbox. So brainstorm those measures and decide where you want to start. As you see here, they decide to look across race, language, genders, and settle on vaccines, asthma, and pain. And you can take a look at it. Hopefully you have the slides. So here's where they looked at asthma well controlled. And they had a comparison group, and then what they call the group of interest, that was the Black population. And they looked at just a simple run chart and said, okay, here is our gap. Here's where we have disparity. And what are we going to look at? So here they described it as the number of missed opportunities for that group of interest. And they defined 2 work streams, clinical operations and other systems related opportunities, as they call them. And you'll see that they had this interdisciplinary work group as a part of this work. Always look at that and ask yourselves as measurement leaders, as QI or patient safety leaders, who is not in the room with us? Whose voice do we need in here that we don't have? So then began, as they did, to evaluate each measure, what they call looking for greatest opportunities by race and language. Again, what I talk about is where is going to be the highest impact and how difficult or not is it to implement. So they did that part of it and began to calculate those missed patients in terms of opportunity by the demographics that they described. And then they built out a graphical display of the work for asthma well controlled. And you see the performance, that what they call actual year-to-date performance, looking at the trends, looking at, is there a change in the disparity in the group of interest as defined by either white or Black African-American. Now, this is an interesting chart, and I encourage you to think about some chart like this, because you will talk to different groups of people, whether it's the board or the microsystem or the mesosystem or the community. So here is what we would call a family of charts. So you have a up in my left side, maybe your right, are the run charts by race. And then you look at just a tabular display over years of the same data by goal and by race and then overall. And then you have just a simple bar graph that demonstrates where the system is overall compared to the goal they set by race or ethnicity, again, for this particular metric. And then when you go back and look at the data, here's the other areas they looked at, including, again, combo vaccines, no-show appointments, and you'll see the other things that they begin to look at, separated out by race. And this is published by the same group from Minnesota in pediatrics last year, and how they began to look at where their improvement was. And I think in this data, there may have been some impact of COVID, but really not much. And they began to look at, are we actually improving or not? And you can see how they color coded that data in ways that people could look at that and begin to understand, was there a favorable change? Was there a decline? Was it unfavorable, where you see there with combo 10 vaccines, or was there no change? Now we're going to show you a different set of data and measurement that I worked on with some friends of mine at More Inclusive Health. And there we looked at equity, inequity, and hypertension. And there we wanted to look at blood pressure data. We set a health system problem statement. This was for a system that had, I think, 66 ambulatory sites. And the metric that we decided on, and I think part of that was for acceptance, is we looked at CMS 165 performance on hypertension. And the data said that almost 65% didn't meet their internal goals. We had the, again, operational definition, or here what we call a measurement description, and what that meant in the system in terms of missed opportunities. And for this system and many systems, it's, where are we on CMS stars rating? How does this compare in MIPS and Medicare Advantage, and again, commercial contracts? So then looking at those measures for a specific population, 18 to 85 years old, the idea was to have blood pressure management measured by a 10% improvement from 2020 to 2021, again, by that CMS blood pressure outcome quality metric. So as we outline that plan again, is we try to make it as quantitative as possible. And these are the steps, the objectives that were in the steps, and then again, a timeline. And as best we can, always have a timeline that reads something like this. Our project planning will involve a phased progression through the 4 objectives listed above, with the goal of achieving a 10% improvement by January 2020. How much and by when? And then it has to be by who. So as we began to look at the data from these clinical sites by race and ethnicity, here's how that data was displayed. And you'll see the variability in that data. And then you begin to see the disparities by practice. And here we went by practice location, looking for where was there disparity. And inside of that, then, was there some kind of inequity that was systematic or unjust? And then how can that be corrected? And then we went further even to say, let's look at all African-American stratified by female, male, by top practices. So we began to look at that data again by practice. We got down to the individual clinician as we began to stratify that data down to the provider level. And you see on this slide where there were 3 providers with large differences between genders. And we thought that was quite interesting, and we want to better understand what was happening with those practices based on their own data around blood pressure control. So when we began to coach the site clinical directors and clinical teams, trying to better understand why these differences existed and what we thought appeared to be systematic inequity. And what we discovered was in one particular practice site, there's one clinician that stood out from the rest. And then just through individual observation, interventions, conversations, what was found was that particular clinician also culturally was raised in a male-dominant society. And he then had relaxed his hypertension control targets for females. So the female patients had worse blood pressure control simply, we think, because of a cultural inequity. And then the clinic director and the system director said, okay, this is a valuable clinician. What we need to do is some additional training around what we would call his bias. Hypertension, again, controlled by ethnicity. We looked at across that system, and you begin to see the actual numbers. Here is Hispanic or non-Hispanic, and looking at hypertension control. You can look at it by educational status, college or non-college or unknown, and then look at hypertension stratified over time, and you begin to see, again, the disparity gap in there that allow you to ask those questions. Why does that exist? So out of that came what we described as, for this system, opportunities for improvement. Where those opportunities exist, are they systematic? How can we improve those? What kind of additional training, coaching is needed? And what kind of support do these practices need that we can get people to better blood pressure control and to a better understanding on the part of the care teams on the importance of hypertension control. Another example here comes from Health Partners, also in Minnesota. Again, a slightly different approach. And here they describe just in simple bar charts where their disparities were. And you can see it's really important that when you begin to put these graphs up, that they're annotated to help people understand, was there something else that we would call a special cause that disrupted something? And in this case, it was COVID. Now, likewise, here, when they looked at optimal diabetes control, you can see at the bottom what their operational definition was, what the hemoglobin A1C was that they wanted to look at, along with blood pressure, were they on a statin, smoking status, et cetera. What were the interventions then, based on their data? And here you can see their 3 interventions, as I just described, that must align your measurement system, your interventions must align with what your operational definitions are, and continue to revisit those processes, as I said before, to make sure there's no shift or drift from your original intent. Another one they looked at, colorectal screening, same kind of gaps were identified by what they described as patients who are white and patients of color. And what were their interventions, as you see listed? They have 3 or so interventions, 3 or 4. I would say think hard about, as you brainstorm your measurement approach and begin to construct your interventions. Once you get beyond 3 or 4, I would say revisit that and have it based on some data and some relative ease of implementation. None of this is easy, so I don't mean to imply that. But once you get up to 4 and 5 and 6 interventions, I think you really got to rethink what are going to be the most valuable ones, the ones that will bring the most impact based on your data that you can then measure. Other one they looked at.
Excuse me, Dr. Wyatt, I hate to break in because this is all so fascinating. I love these examples. Do you think we could wrap up in like another minute or so we can get time for a few questions?
Oh boy, the time goes by so fast.
It goes by so fast.
Yeah, you'll so I'll stop, but this is fun for me. and I wasn't looking at the time, so I apologize. You'll have the slides. I would say remember that there are levels of action. Here we're talking about strategic action that you can operationalize and build tactics around. And first and foremost, it's got to be the patient, the person, and the community, the care teams. We talked about the micro system and the macro system being involved, and payment and policy. And look at what are those structural opportunities that you can identify. Always use some interdisciplinary team. Use as best you can, a standard quality improvement methodology. Look at your operational opportunities. Don't do this without the community. So that's co-design and co-production. And last, I'll say, learn as you go and have fun with it. So I'm going to stop. Thank you.
Thank you so much, Dr. Wyatt. Really appreciate sharing with us. So I'm going to just go right into Q&A. Sophie, you're up first if you want to ask your question.
First of all, thank you. Amazing amount of information, and I'm happy we'll get the slides. So much to digest. You got to it towards the end, so you kind of answered it, or you indicated the importance of engaging patients in the community, but still many of the examples started off with the measures. And I feel that's something that we really struggle with is how do you decide where to start? We have so many partners that are ready to really do this well. And then if we start with the community, whom and how to do that well. And if we start with the measures, already there, it can, I don't want to call it rabbit holes, but it's a path dependency because it's so much investments and analysis needed. So how do you balance that? And where have you seen that being done really well?
Yeah, so it's going to always start with, what I call the work before the work. And the work before the work is, again, to say, where can we get the most impact and is easier to implement based on the data you already have. So I would say most places have so much data right now, you don't need to try to find new data. So I usually say, start with the data elements that are mandated or required. What are those things that are already being looked at, and look at those data sets? Is it readmissions? Is it mortality? Is it diabetes control? Is it in the outpatient setting, pediatric vaccination, immunization rates? So start with things that are straightforward, that are already required and mandated. Try to get that data, stratify that data, and that's going to tell you where to start with a population or even a subgroup. So start there, start small, and it's important to your point that so many people want to do this work, keeping people engaged. And think about if you're in a setting where you have a patient family advisory council, that's terrific. If not, then seek out people in the community leaders. That's what that organization did up in the upper Midwest, that some of these voices you likely have already heard from. And in some cases, it's uncomfortable, right? Because, here she comes again. But reach out to those people, embrace what they're trying to say to you, and listen. That's that humility I talked about. What is important to them in the community? You might be surprised. You think something's important because it's important to you. Ask them, what's important to where you live? What's important on your street or your block or your neighborhood or your street or your road? And start there. Okay, they say that this is most important for us here. And you may be surprised. It may be the buses don't come on time. Well, how does that impact health? It does, right? So then think about, in an innovative way, can we do something with that? You can say, okay, if the buses aren't running on time, is that impacting our no-show rate, right? So begin to think about, what does that mean to patient care? And we can easily say, well, this person didn't show up, they're no-show again, they're non-adherent, we give up, right? But they're telling you it's because I don't know when the next bus is going to come by, right? So being curious about it and asking the people in the communities, what is important to you? What are we missing? What do you see that we aren't seeing? And that's the humility part of it. And then go and try to act on it. This is now about action. We're past raising awareness. You don't need to tell people in these socially vulnerable groups that things are bad. They already know it, right? So you're asking them permission to help you with this. And then you go back and look at what's the relevant data that we can build on to improve care for those populations. I don't know if that answers it, but that's how I would go about it.
I will welcome Sunita next.
Great. Dr. Wyatt, thank you so much. I'll echo what Sophie said, lots and lots of content. I'd like you to put on your consultant hat for a moment. Given the number of these efforts that you have seen, are there, like, what are the tried and true 2 or 3 interventions that we should all be doing so that we can look at, like, what's the consistent pattern? I get tailoring, I get needing to understand our context, but are there just some big examples that come to mind for you that you just say, you know, we should all just be starting doing these interventions as a first pass?
Yeah, the first pass is something that's simple, but not. Are you collecting and stratifying race, ethnicity, and language data? Are you collecting and stratifying sexual orientation, gender identity data? Do you have some type of program beyond cultural competency? Whether that's implicit bias training or anti-racism training. But I would always start, and I say that because all the big payers, including CMS and big entities, again, including the Joint Commission, are looking at and will ask you, are you collecting race, ethnicity, and language data? Are you stratifying it? And when I even look at the organization I work with at Ivy League organizations, the leading category when they look at their race, ethnicity, and language data is, guess what? Unknown. Unknown. So begin to look at, okay, are we investing in resources? Are we building capacity and capability around just asking a person, what's your preferred race or ethnicity, right? Is that data being collected and validated? Do you have a system that can validate that data at different points throughout a hospitalization? So example, a good friend of mine at Hopkins, whose mom went into the hospital, told everyone she was African-American. At the time of discharge, they had on her discharge papers that she was white. And she looked at it and said, no, I'm African-American. And the nurse even said, no, you're not, you're white, right? So if you start anywhere on improvement, if we're going to talk about disparity and equity, are you collecting and validating your race, ethnicity, and language data? And build off of that.
Thank you. Just want to take a moment. I didn't see any other questions in the chat. Does the group have additional questions for Dr. Wyatt before we move into small groups?
I'll raise one that I haven't heard you mention explicitly, and that is around health literacy. Can you tell us, in terms of thinking about either best practices or where does health literacy fit into using that to stratify data?
Yeah, so that should be a part of a robust data collection plan, right? Are you collecting that data on literacy levels? What should that look like in your population? I'll give an example. We decided when I was at the military health system that every piece of communication that we printed for people was at 3rd grade level. And this is for the entire U.S. military system. So looking at, do we have information that people understand and can read? Do you have, and this is one of the things that the Joint Commission, I assure you, will be looking at, and I recommended it years ago, is do you have adequate interpretive services? Right? And that doesn't mean put somebody in a room with the person because they're a quote unquote native speaker. That's not qualified interpretive services unless you can document, you put people through that kind of a process. Do you have materials or access materials in a person's preferred language? How many languages are spoken in your service area, in your organization, and how do we meet their needs? So for instance, at Cook County, we looked at this. The languages were English, the second most common one was Spanish, the third was Polish. So we make sure that the Polish population had information that they could understand. So that's just the kind of the big space that health literacy occupies. What now we got to start thinking about it with COVID and telehealth is digital literacy. So begin to think about that as well. But begin to say, where are we now? What is the baseline, and where are we falling through, and how can we improve that? I always again say, go to your HCAHPS data, and I'll give you an example of where we failed at Cook County. We had a person come to a board meeting. How embarrassing. And she said that when I come to my clinic, I love my care team, but I always have to wait because you only have one person in intake that speaks Spanish. And over 90% of the patients were Spanish speaking. Right. So the site director, well intended, said, okay, we need to get another person on the front desk that can help us with this kind of now process that was failing people and leaving them dissatisfied. So we need to put another person on the front desk. And oh my goodness, she hired a person that didn't speak Spanish. So now you compound the problem. You have two people that don't speak Spanish. Now you have two people going to the native speaker, the manager, asking them to help with interpretive services. So look at your processes and think about what we call health literacy and all those terms from the point of view. And that's again, humility from the perspective of people in the community. What are we missing with your care, right? How can we do this better? And they will tell you. And then you have to advocate. And I always tell people, activism and advocacy are not the same thing. So advocate for the community based on what the community tells you they need. And that's a long-winded answer because there's no kind of, I don't think, a fairy dust to health literacy, except for meeting the people's needs.
Well, thank you so much. And thank you so much, Dr. Wyatt, for your entire session. It was just great to hear from you and all of your knowledge and expertise in this area. So hopefully everyone on the call can join me in thanking Dr. Wyatt for this session today.